Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Blanchette. Today's episode features coverage of the 2020 Digital International Liver Congress, organized by the European Association for the Study of the Liver. During this podcast, Dr. Stefan Zeuzem from the J.W. Goethe University Hospital in Frankfurt, Germany, will discuss important new viral hepatitis data presented at the Congress, including studies focused on HCV elimination and the treatment of hepatitis C, hepatitis B, and hepatitis delta. For more information on Dr. Zeuzem and for a link to additional online CCO coverage of the Liver Congress, including a downloadable slide set covering the studies discussed in this episode, please visit the show notes. Now let's get started and hear what Dr. Zeuzem has to say about these new data. Welcome, Dr. Zeuzem.
Thank you, Jen. Hello to everybody around the globe. Nobody had to travel back from EASL. It's the first time that this meeting was organized in a virtual way. I was quite impressed how well it was organized. But I must say I'm missing contacts to my colleagues and peers, discussions in the breaks, and sitting just in front of a computer for almost 3 days was a little bit exhausting. But I think we put an interesting program for you together, a rapid recap, as we called this EASL 2020 conference coverage. So we looked into a couple of issues. First, HCV elimination, progress, uptake, and implementation strategies. We have chosen one topic in the treatment of HCV infection, and we also look into some hot topics in HBV infection, and this will be followed by a question and answer session. And I hope I'm able to answer all your questions at the end of this program. So let's start with HCV elimination, progress update, and a look on implementation strategies. There is a big group around Homi Razavi in the United States who does really an incredible job in using an updated Markov model to evaluate the progress towards HCV elimination in actually all countries around the world. And here at EASL 2020, he reported the updated numbers in high-income populations using his model. He used demographic and epidemiologic inputs sourced from the World Population Prospects and this Polaris Observatory, which is the organization which monitors for several diseases very carefully the current epidemiology. They added annual new diagnosis of HCV to the model and the treatment data from 2017 to 2019. They pinpointed the time frame each country likely to achieve the WHO targets. Just to remind you of the WHO targets, they ask us to achieve an 80% reduction in incidence, 65% reduced mortality versus the data in 2015. They wish us to diagnose 90% of patients and 80% should be treated. And we then have here the countries which are on track. We have currently only 11 countries which are on track to eliminate HCV in the WHO provided time frame until 2030. These are currently Australia, Canada, France, Germany, Iceland, probably the country which quickest is going to achieve elimination of HCV, Italy, Japan, Spain, Sweden, Switzerland, and the United Kingdom. 10 years behind are another 5 countries, and 1 year behind, another decade behind, another single country, Saudi Arabia. However, the vast number, unfortunately, of high-income countries will not be able to eliminate HCV if they continue with their current practices before 2050. And these are listed on the right column here. And there are a number of surprises for me, because some countries definitely would have the opportunity to perform much better and to be by far more aggressive in terms of diagnosis, linkage to care, and treatment. So, to summarize, among the 45 high-income countries, WHO elimination targets for HCV estimated to be met by 2013 only in 24% of the countries, an additional 11% by 2040, and by an additional 2%, this was Saudi Arabia, by 2015. Remaining 28 countries, 62% of all high-income countries, are off track by at least 20 years. And we have still 11 of those 28 countries which still endorse treatment restrictions related to fibrosis level, which is really definitely scientifically, clinically, and ethically outdated. The analysis assume that HCV diagnosis and treatment rates maintain at current thresholds. Service expansion will be critical to improve targets. Of note, 3 countries previously off-track for 2030 have course corrected, and 1 country which was previously on track for 2030 has slipped to the by 2040 stratum. Canada focused elimination efforts in population provinces. Germany improved diagnostic tactics, and Sweden removed fibrosis-related restrictions on HCV therapy, while on the other hand, South Korea has experienced declining treatment rate and lacks comprehensive screening initiatives. So clearly, things can be improved. There is no reason that countries remain in a certain bucket. Those who are in a good bucket, a green bucket, have to continue with their efforts. Those in a yellow and red bucket can still improve their strategies and be back on track, what is envisioned by the WHO. So this is a perspective of complete global elimination, and it's very interesting to also look into issues of micro-eliminations. And we know from various modeling that indeed diagnosis and treatment in prisons is one of the key issues, because there's a big overlap of patients and persons who are injecting drug and the inmate population in prisons. Australia was very engaged here and run a large interventional clinical trial enrolling incarcerated persons across various parts of Australia into an open prospective cohort beginning October 2014. They had 2 prisons with maximum security and 2 prisons with kind of medium security. I'm not quite sure how this is defined, but probably related to the amount of barbed wire around those institutions. The HCV status and risk behavior was assessed as baseline and every 6 months thereafter. And if uninfected or previously infected, those persons were followed for primary infection or for reinfection, respectively. And if infected, they were evaluated for HCV therapy. Intensive treatment with DAAs began in Australia to be scaled up in the mid-2017s, with 12 weeks of sofosbuvir valproic offered to all HCV RNA positive individuals. And the HCV incidence compared to periods before 2014 to 70 versus after 2018 to 2019 really show a big treatment scale up and interesting data with respect to the HCV incidence. In the little table on this slide, you see some characteristics of the prisoners. There is almost half of them who have never injected drugs, but you see that there is an additionally and similarly high proportion of patients who have used drug before current imprisonment, or continue this during the current imprisonment. And there is at almost a quarter of those patients who have continued the use of injectable drugs within the last months. There is a little bit more than a quarter of those people engaged in opioid substitution treatment. And what is a big concern, that the Australian prisons are providing treatment, but no dispensable and one-use equipment, and therefore the rate of shared injecting equipment is incredibly high. On this slide, you see the trends for the primary HCV infection and the HCV reinfection on the left and the right panel, respectively. And if you compare the two time frames, 14 to 17 and 18 to 19, you definitely see by scaling up treatment that there is a substantial decline in HCV incidence per 100 patient years. And if you look at the right panel, there's also a predicted trend if this large uptake of treatment would not have been initiated. And you see how much the observed trend improved the situation in prisons in Australia. There are some factors associated with HCV acquisition. The study period shows that the high treatment rate, being it a lower prevalence or being it more awareness of prisoners themselves because treatment was offered, declined in the study period 18 to 19. The previous in prison increases the risk of HCV infection, and the injecting drug status in the current imprisonment also has a major impact on HCV infection. So it's particularly high, 6 times higher than if somebody has not used injecting drugs. So if somebody has used injectable drugs within the last 6 months, the risk is tremendously increased. Interesting also the prison site at the last visit. I would always have anticipated that the risk, and this is the situation at least in my country, that female prisons have a much lower rate of HCV infection. But here it turned out to be somewhat the opposite. So Didvinier is a female prison, had actually the highest risk of acquiring HCV for me unknown reason. Certainly interesting to elaborate and learn out of these further analysis. So clearly microelimination even in these difficult environments is possible and is certainly going to have a major impact also when those prisoners are discharged and back in their community, in avoiding any third people being infected due to the fact that they were cured while in prison. Treatment of hepatitis C infection is the next topic I would like to cover. We have excellent drug. We have 2 drugs, clestovir and biprentosvir, as well as sofosbuvir, velpatasvir, which achieve incredibly high sustained virologic response rates in the first treatments. Nevertheless, 1 or at most 2% are failing those first-line therapies. And the question is, what can we offer to patients who have failed a previous regimen? And here the shared consortium were collecting data from a large number of patients, 130 patients, various countries infected with various different genotypes, predominantly genotype 3A and 1A, the typical genotypes which fail in the first run. And they actually looked for treatment failure particular in two regimens, that is the GP regimen and the triple regimen of sofosbuvir, velpatasvir, and the protease inhibitor voxilarprovir. So here we have a look first on patients who failed GP. Here we see that over 90% of GP failure patients were retreated with Sofwel-Vox, and almost 100% of patients who failed the GP regimen actually achieved a sustained virologic response rate with the triple treatment sofosbuvir, velpatasvir, voxilarprovir. If you recall, the approval study of Sofwel-Vox enrolled patients which were historically treated or failed the earlier DAA regimens. And there was no patient in the original publication authors by Mark Bullier and published in New England Journal some years ago, who were actually pre-treated with GP because GP was not yet available in those days. So we had clearly missing data. What is going to be the chances of Sofwel-Vox in patients who failed GP? And it's really great news that even with GP failure, Sofwel-Vox is eradicating in a second round the hepatitis C virus. And this happens actually across all genotypes. There was no selection of certain genotypes which did better or worse. Really across all genotypes, almost 100% were cured with this regimen. Fewer patients were retreated with Sofwel. That is certainly not what we would recommend. If you look at the variants which were selected by GP, you see in the little table on the right side that GP failure is typically associated with selection of variants in the NS5A region and less frequent in the NS3 region. And there is a substantial proportion who have actually either the NS5A or the NS3. So if you look for genotype 1A, more than 90% have selected for variants. In genotype 3A, almost 80% have selected variants for either of those drug classes. And here you see the selection of RAS in patients have failed sofosbuvir, velpatasvir, voxilarprovir therapy. This is a very rare occasion, and it's very active group that they collected 20 patients who have failed. It's even a little bit more. It's 49 patients who have ever failed sofosbuvir, velpatasvir, voxilarprovir. That was a big effort to find those patients. And you see in genotype 1A, there were 11 patients who failed therapy, 19 with genotype 3A. These are the predominant genotypes which may create or may be associated with failure. And there are a few 1Bs which failed Sofwel-Vox therapy, but they could not collect any other genotypes here. Most important is here the fact that the triple therapy is confirming data from the just mentioned study from Mark Bullier that indeed the triple therapy is not selecting for new variants. You see in blue the RAS situation at the baseline, and in red after Sofwel-Vox failure. And you see that on average the bars are pretty much similar, clearly showing that indeed a regimen consisting of 3 mechanisms of actions, such as it is the case with sofosbuvir, velpatasvir, and voxilarprovir, is not selecting for any variants, and therefore giving better chances, if ever necessary, for a retreatment. Retreatment of patients who failed Sofwel-Vox is typically recommended in the international guidelines to comprise a regimen of GP plus sofosbuvir, and there is no consensus on the duration of therapy. It's ranging from 12 to 24 weeks of therapy, and the addition of ribavirin is at the discretion of the treating physician. We have not received all final responses from all retreated patients who failed triple therapy, but you see that there's a number of patients who achieve sustained virologic response in the retreatment with GP plus SOF plus or minus ribavirin. But you also see that in the second lowest column of the left side, that there is, for example, a patient with genotype 3A who failed again retreatment, even with the most advanced regimen given here for 16 weeks. And you see in the last row of the right-hand figure that another 3A patient was retreated for 24 weeks, but he was retreated with Sof-Vel, not with GP and not with sofosbuvir, and he failed therapy. Therefore, my recommendation personally, if you get it reimbursed, is always, if you have patients who failed Sof-Vel-Vox and you go for a GP plus Sof treatment, I probably would always choose 24-week treatment duration. And if it would be possible from the hemoglobin of the patient, I would probably also add ribavirin. So summarizing those shared cohort findings, is that approximately 1/3 of patients with GP failure have no resistance, meaning that 2/3 have selected for variants. The majority of patients with triple therapy failure, Sof-Vel-Vox, did not have specific emergent RAS pattern versus baseline, so there is a clear difference between the two regimens. And retreatment with the triple therapy after GP failure is highly affecting achieving almost 100% SVR rates, and most importantly, achieves SVR across all genotypes. Among patients with triple therapy failure, those with genotype 3 and 1A, and probably those with cirrhosis, are the most difficult to retreat, and rescue therapy should probably comprise GP plus sofosbuvir plus or minus ribavirin, as we just discussed. Now, this is another study looking into GP and triple therapy, and I don't want to guide you through all the details, but the question was, if you have failed as a patient with any previous DAA therapy, dual therapy, DAA treatment, what may perhaps be the better retreatment choice, GP or Sof-Vel-Vox? Since there are no head-to-head studies available, the authors around Stephen Flum tried to collect data from a large cohort and matched those data accordingly, trying to find equal groups and to give, at least in this retrospective way, a possible answer on which regimen may be superior for patients suffering from failure to original therapy. And here we see that overall, in both the intent to treat as with the protocol, per protocol analysis, that overall the retreatment sustained virologic response rate were high. But if you compare the two regimens, for example, if you go to the row of ledipasvir, sofosbuvir, which is the white line, fourth line on the slide, you see that in the ITT analysis, 95% were cured after DAA failure with triple therapy, but only 83% with GP. And if you look in the protocol analysis, this was very similar. So apparently, there may be differences between the two regimens, and overall the data also after propensity score matching, trying to balance the baseline characteristics of the patients in the registries, remain with a hint or some evidence from such a retrospective analysis that in particular patients who failed a ledipasvir-sofosbuvir regimen or a sofosbuvir-velpatasvir regimen, that here there may be an advantage for retreatment with Sofvel-Vox over clezapravir-B-prentosvir with respect of achieving an SVR. Nevertheless, it's not a head-to-head prospective trial, but I think it's the best we can get in terms of data, because I cannot envision, due to the small numbers of patients and other reasons, that ever a prospective trial will be performed for this question. So let's have a look on HBV therapy. I think this was the highlight of EASL meeting, and this is a multi-center prospective trial, not of a new compound, but rather of stopping patients from a long-term nucleic acid treatment, patients all E-antigen negative. So we had here patients which had normal aminotransferases receiving either in the majority entecavir or tenofovir for at least 4 years, and they were necessary not to have progress to advanced fibrosis or cirrhosis. Also, patients with viral co-infections were excluded. So here, 158 patients were randomized either to continue with the respective NUCs for another 2 years, or to discontinue the nucleic acid, the NUC therapy, and see what is going to happen in patients where the treatment is stopped. The primary endpoint of this study was HBeAg-antigen loss after week 96, so after 2 years. And there were some secondary endpoints. That's the time of HBeAg-antigen loss, the time to seroconversion, the virologic response, biochemical response, the time to fulfill retreatment criteria, and the proportion of sustained remission, which was defined as HBV DNA less than 2,000 IUs per ml and normal ALT. And here you see on the right side the graph. The red line represents patients who were continuing treatment on the NUC, and there was not a single patient who lost HBeAg-antigen. However, in the group of patients who discontinued the NUC after at least 4 years of therapy, you definitely see a number of patients over time, no specific time points. So the loss of S-antigen can appear early, it can appear late in the course of discontinuation, but overall 8 patients, which refers to 10.3%, have lost antigen. No treatment was indicated in another 70%, almost 70% of patients. So 2/3 of the patients, 67.9%, 53 patients, did not meet the indication to restart therapy with a NUC after stopping it after 4 years of therapy. Retreatment was indicated in 6 and actually initiated in 11 patients. So the big message here is almost or around 10% of patients lost S-antigen. And if you compare this to a number of currently evaluated new medications in the hepatitis B field, investigational compounds, one must state that probably the next control of the new investigational compounds must be, again, discontinuation of NUC therapy, at least in the E-antigen negative population, because that is now a kind of new standard of care in non-cirrhotic E-antigen negative patients. Few more data were presented. The loss of S-antigen was most favorable and most frequent in patients who had an S antigen at baseline below 1,000. So I think that's a clear message. If you have a message to a patient tomorrow who is on long-year NUC therapy and he has an S antigen level at baseline when he was started with a NUC below 1,000, it's probably worthwhile discussing with this patient as long as he's non-cirrhotic to stop therapy, because in this population with low HBs antigen at baseline, 28% lost the S antigen by stopping the therapy. And there was no difference between the previous NUC therapy, so apparently there is not a specific NUC which is favoring this loss of S antigen. If you look now at response and safety, it's quite a non-brainer that if you stop therapy, you're not expecting additional side effects. Nevertheless, they were covered, but they were, of course, not drug-related because the drug was stopped. Continuation of NUC therapy showed 8 severe AEs, which are listed here. They may be causally related or just associated, but I see a couple of them which probably are even causally related to continuation of NUC therapy. On the left column, you see the outcome after 2 years in patients without retreatment. You see that there is 2/3 of patients who have HBV DNA above 20 IUs per ml, but there are almost 20% of patients who are below 20 IUs per ml. There is a huge proportion of patients who maintain normal ALT levels, almost 80% after discontinuation and 2 years after stopping the treatment. And there is a substantial subset who actually have a sustained remission, and nevertheless they need to be followed up. They may have a later reactivation requiring restart of therapy, but I think it's really good news that something which is moving into clinical practice. The EASL guidelines have already mentioned discontinuation of NUC in this population as a possible treatment. I think HBeAg and AASLD guidelines have to consider those data now as well, and perhaps reconsidering their recommendation, because here stopping a NUC in E-antigen-negative is not yet supported unless the patient loses S antigen during therapy, which, as we see in this study, never or very rarely happens. The last couple of slides are just summarizing what kind of drugs we currently have approved. We have the nucleoside analogues, which are reverse transcriptase inhibitors, and we have pegylated interferon. And I like to mention that there is a large number of new compounds being developed, being entry inhibitors, HBs antigen release inhibitors, immune modulators, inhibitors of protein translation by siRNA, cccDNA silencing compounds, and core inhibitors. There were a number of interesting data presented, which I'd just like to cover briefly. There was the compound against hepatitis D with another study presented. So here the entry inhibitor bulevirtide was given at 10 milligrams once daily subcutaneously in combination with pegylated interferon, or as a monotherapy or as a combination therapy with tenofovir. And the primary endpoint was HDV RNA undetectable rates at week 72. So people were treated for a year and followed up for half a year. And it's good news for our patients with delta hepatitis, especially the combination of bulevirtide, which is now already approved in Europe, in combination with pegylated interferon, showed very good synergy and showed substantial HDV RNA undetectability at the end of therapy. achieving 86.7%. And if you look at the week 72 outcome, so after 24 weeks of follow-up, we had still 7% of patients HDV RNA undetectable. We had 1/3 of patients with ALT normalization, and 2 patients lost the S antigen. So clearly the combination PEG plus bulevirtide is superior, according to those data, than bulevirtide in combination with tenofovir. A couple of other data were shown of RNA interference, a compound from Janssen, which is also now moving in combination therapy with other compounds. That is a compound which is, of course, targeting viral RNA and can achieve substantial decline in S antigen. We'll see how this is maintained once you stop the therapy. There is a compound now known as GSK836, which is working also by RNA interference, showing very profound HBs antigen reductions, but in some patients even more than 3 logs, and it was generally very well tolerated. So I'm sure we're going to see even more data on these compounds in the future. And I also like to mention the 2 other drug classes, core protein inhibitors. There was an interesting new compound called vebicorvir, which had a nice safety profile and had some early interesting data in e-antigen-negative patients. And there was, last but not least, a compound being investigated as a TLR8 agonist. And here, 5% of patients, 1 out of 50 patients, achieved HBs antigen loss, which, of course, compared to the 10% of stopping the NUC treatment is a little bit disappointing. But still, immune modulators are needed. Therefore, the TLR8 agonist class may be still interesting to follow up, but I'm not quite sure what is going to be the next clinical program of this compound in forthcoming clinical trials. With that, I'd like to finish. Thank you for your attention. And if there are any questions, I think we still have a couple of minutes time to answer them.
Great. Thank you, Dr. Zeuzem, for that presentation. We have had a couple of questions, so we'll get through as many as we can in the next couple minutes. A participant named Ulrich asks, which is, in your opinion, the most promising mode of action in the new approaches for functional cure of chronic hepatitis B?
Of hepatitis B, you mean?
Mm-hmm. Yes. Sorry.
Yeah.
Yes.
If you take the data from EASL, stopping NUC therapy is highly effective. So that is going to revolutionize also the clinical trials in the future, and especially for the e-antigen-negative patients being on a NUC. Clearly, if you take it away from there must be combination therapy. And I guess certainly some with interference of messenger RNA decreasing the SI, decreasing the S antigen will be key. And nevertheless, we have to wait for those trials, and the on-treatment response will not be crucial. We really have to wait until those drugs are stopped and see what kind of response is going to be maintained.
Mm-hmm. Great. So another question that's actually related to the Stop-NUC trial. Mark asks, although in e-antigen-negative patients, discontinuing therapy resulted in a 10% S antigen loss, but what is your view on the HCC risk in those who discontinued but didn't achieve S antigen loss?
Yeah, it's an interesting question whether those who discontinued may have a slight increase in their incidence of HCC. Nevertheless, we know that the EHCC incidence is highly correlated with the HBV DNA levels, and we have seen that those who lose S antigen have no detectable HBV DNA, and that there are even more patients which really remain at very low levels of HBV DNA, that I think that the overall risk, indirectly speculating, is not going to be incredibly or clinically significantly increased. And this has to be also balanced with the willingness of the patient to take antiviral agents for the rest of his life, and for potential side effects there as well on the long-term application.
Great. Okay. Chris asks a question about the shared cohort and how treatment failure was defined. The question is, given that 1/3 had no resistance after GP treatment, is it possible that some of these individuals were reinfections as opposed to treatment failures?
Yes, that is always a potential reason, but this would require diligent phylogenetic analysis and sequencing of the virus to rule this out. So there have been studies in the past that late relapses, up to 50%, were actually new infections. And it's certainly fair to state that we cannot exclude this possibility.
Okay, great. Okay, I think we have time for one more. Neil asks for your thoughts on to what degree is HCV elimination, related to the DAA reimbursement strategies that are taken in different higher income countries? Is it just a matter of whether treatment is paid for or not?
I think you have, of course, to differentiate according to the individual healthcare system. You have, of course, the high-income countries, 45 countries, where actually reimbursement should actually not be an issue. And then there have been a lot of modeling showing that it is absolutely cost efficacious to eliminate HCV in terms of avoiding late complications of cirrhosis and cancer. Nevertheless, even though those drugs are generically available in many parts of the economically less wealthy part of the world, it's still prices sometimes very prohibitive for the general population. And here really programs have to be started by the government and health care authorities to make access and availability at low or actually no costs available for the population, because of the major benefits in avoiding later complications and costs.
Great. Thank you very much, Dr. Zeuzem, for providing this important information. And thanks to all of you for listening in. As a reminder, to view CCO's full program covering the 2020 Digital International Liver Congress on the Clinical Care Options website, click on the link in the show notes. Please be sure to check back regularly for more episodes on important infectious disease topics. Thanks.